The following module discusses the socio-economic status and mortality in terms of conceptual understanding, indicators for health and mortality. Also discussed are the relationships between education and mortality, income and mortality, and the influence of socio-economic status on mortality. As will be discussed, socio-economic status has many dimensions, including not just education and income, but also community standing, power, wealth, and other dimensions, and occupation is a widely used indicator wherein further subgroupings are also made for analytical purposes. Analyzing data by socio-economic status often reveals inequities with regard to access to resources and issues related to privilege, power and control, and higher levels of socio-economic status are seen to reduce mortality risks through different mechanisms, reducing exposure to factors that lead to morbidity, disability, and mortality. For instance, education has been seen to have an association with mortality levels, particularly child mortality, as education through awareness and knowledge has increased levels of health services utilization and practices, reducing morbidity overall. Income is also seen to have a relationship with mortality levels such that the socio-economic living standards measured at the household or at the aggregate level. In India, all large-scale surveys in recent years, such as the National Family Health Survey (NFHS), the District Level Reproductive and Child Health Survey (RCH), and the National Sample Survey Organization (NSSO) data on morbidity have revealed an inverse relationship between various standard of living indicators and mortality. For instance, a wealth index calculated in National Family Health Survey 3 based on asset and household characteristics show that the lower the wealth quantile, the higher the under 5 mortality. There are other arguments as well which can be understood by going through the module contents that refer to the impact of behaviors and with regard to individual and household level variables as shown through different studies. These determinants can be used towards providing comprehensive, long-term and equity-based public health interventions and immediate infant care programs.
I am Dr. C.P. Prakasham, retired professor from International Institute for Population Sciences, Mumbai. Module 23-24, Socio-economic status and mortality. In this module, we will learn the socio-economic status and mortality. Number 1. Socio-economic status, a conceptual understanding. 2. Socio-economic indicators for health and mortality. 3. Education and mortality. 4. Income and mortality. 5. Influence of socio-economic status affects the mortality. A conceptual understanding. Socio-economic status, SES, is an economic and sociological combined total measures of a person's work experience and of an individual's or family's economic and social positions in relation to others based on social status, education, income and occupation. Socio-economic status refers to a classification of an individual, household, or a family according to occupation, income, education, or some other indicators of economic and social status. Socio-economic status often reveals inequalities in access to resources plus issues related to privilege, power, and control. Occupation is the most widely used indicator of status, though it entails the grouping of many diverse occupations into a smaller number of broad categories for the purpose of analysis. Socio-economic status has various dimensions, including not only education and income, but also community standing, power, and wealth. Higher level of ACS can reduce mortality risk through a number of mechanisms in variety of institutions and for numerous causes of death. Adler et al. 1994. High ACS often reduces exposure to factors that leads to morbidity, disability, and mortality. For example, individuals with higher income and occupational status often work in jobs that entail little exposure to physically demanding, emotionally stressful, or environmentally unsafe working condition. Monson 1986, and can afford safer housing in less dangerous neighborhood. Robert 1999. Socio-economic indicators for health and mortality. Studies have shown following socio-economic indicators interlinked with health and mortality. 1. Poor people die at a greater rate than rich people. Blacklund et al. 1996, Davy Smith et al. 1998, Kofam et al. 1998, Sorley et al. 1995. Number 2. Poorly educated people, illiterate, die at a higher rate than highly educated people. Friedman et al. 1989, Fox and Goldbert 1982, Kunrad and McCabe 1994, Skeletoner 1998, Solid 1995. 3. People from lower socioeconomic classes die at a higher rate than those from high socio classes. Fox and Goldbert 1982, Solid et al. 1995. Each incremental improvement in socio-economic status is associated with an incremental decrease in mortality risk. Hodwin, Champman et al. 2000. All above factors directly and through other factors experience mortality. Education and mortality. The status of education has a protective association with child mortality in India. Singh, Monax et al. 2008. It enhances the level of awareness and knowledge of right health and hygiene practice. So, education through the path of awareness and knowledge affects the level of health care services utilization with righteous approach and resultant to that control the morbidity status of the household in particular and in the region in general. In case of maternal and child health status, literature has shown that lower level of maternal education were associated with higher maternal and child mortality even amongst women able to access facilities providing intrauterine care. Burgard 2004, Saffron et al. 2011, Roy and Chavan 2014. As level of education enhances of parents, the infant and child mortality declines, especially the education of mother. Educated mother has better knowledge about raising and carrying practices of child and even their own health, so she would be much capable of reducing the morbidity status and opt for good health status. Income and mortality. Many studies reveals The relationship between income and mortality. The most frequent cited correlation of mortality is socio-economic living standards measured either at the household level or at the aggregate level. Smith, 1999. In recent years, with the diffusion of medical technologies in developing countries, the general practice is that mortality is increasingly being disassociated from economic factors. Preston, 1976. It is argued that due to limited resources, poor scheduled caste households do not pay for health care expenses, while the remaining non-poor are wealthier and better educated or have well able to deal with travel for their health needs. Cleland and Van, 1998, all of which may facilitate the use of maternal care. In India, all the large-scale surveys conducted in recent years, 3 rounds of National Family Health Surveys, NFHS, District Level Reproductive and Child Health Services, RCH, and the NSSO data on morbidity reveals inverse relationship between standard of living and mortality. Table 1 reveals that women with no education, illiterate, experience under 5 mortality found to be more than educated women. With the increase in education level, under 5 mortality decreases. Wealth index, which has been calculated in NFHS 3 by using 33 assets and housing characteristics, reflects the household economic status and consistency with expenditure and income measures. Riston, 1999. Wealth index, which has been divided into 5 quintiles, shows that lower wealth quintile experiences highest under 5 mortality, and as the wealth index increases in under 5 mortality reduces, and it becomes 1/3 when compared to lowest quintile. Another possible argument for the observed relationship between income and mortality is that it is a reflection of bad health related behavior of the poor people. Health related behavior such as use of tobacco, smoking, consumption of alcohol, etc. is generally found to be higher among the socio-economically backward section of the people in many countries. However, the study have also indicated that such behavior can explain only a part of the income mortality gradient, Decon 202. Although access to care and bad habits are important in mediating the relationship between income and mortality, they may not be able to explain the income mortality relationship in India. James and Shyamala, 2010. In 1984, Mosley and Chin, 1984, proposed an analytical framework for the study of the determinants of child survival in developing countries. They suggested a range of socio-economic determinants which operates through the proximate determinants to influence the level of growth, flattering and mortality. Mosley and Chin grouped these determinants into 3 broad categories of variables. Socio-economic determinants influencing child mortality through proximate determinants. 1. Individual level variables. 2. Tradition, norms, attitude. 3. Household level variables. 4. Community level variables. The proximate determinants which affect child mortality are grouped into 5 categories. 1. Maternal factors. 2. Environmental contamination. 3. Nutrition deficiency. 4. Injury. 5. Personal illness control. Based on the premises, Mosley and Chin, 1984, explained how the dependent variable child mortality is determined by independent variable socio-economic determinants which necessarily operates through a common set of proximate determinants. Mosley and Chin, 1984, in their model, by limiting the proximate determinants to 14 specific factors grouped into 5 broad categories, thus are able to make feasible the integrated analysis of the biological and social determinants of mortality. Research studies also show the relationship between mortality and socio-economic variables. Caldwell 1979 examines education as a factor in mortality decline using the Nigerian data. He stressed on the role of potential education, particularly that of the mother, in reducing infant and child mortality. He argues that a well-educated mother can change the range of feeding and child care practices without imposing significant extra costs on the household. Kishore and Parasuraman 1998, using data from the 1992-93 National Family Health Survey, found that mother's income translates into greater control over the expanding of resources, increased exposure and access to relevant information about childbearing and child rearing practices. Their study showed that mothers who are employed have a 10% higher infant mortality rate and a 36% child mortality rate than mothers who are not employed. Kim Bahadur Khadak et al. 2011 studied socio-economic distal and proximate determinants are associated with infant mortality in Nepal. Nepal DHS data analysis revealed that infant mortality was higher in the poor and middle class than the wealthier classes. Population mountain ecology regions and far western development region had high risk of infant mortality. Similar infant dying was higher for infants whose birth size, as reported by mother, was very small and who has higher birth rank and shorter preceding birth interval. This study uniquely addressed both broader socio-economic distal and proximate determinants side by side at the individual, household and community level. For this, both comprehensive, long-term, equity-based public health interventions and immediate infant care programs are recommended. Questions. Number 1. Describe briefly conceptual understanding of the word socio-economic status, SES. 2. Describe the interrelation between socio-economic indicators influencing mortality. 3. Describe briefly the influence of education, income on child and infant mortality. 4. Describe briefly Mosley and Chin 1984 analytical framework. Following are the important references. Thank you very much.
Technology has enabled the expansion of medicine and has improved the overall health of the global population. However, not all people have the same access to quality healthcare. Inequalities in health include differences in rates of disease, health outcomes, and access to healthcare. Often, inequalities in health are the result of social inequalities. Differences in socioeconomic and environmental factors may present barriers to entering the healthcare system, resulting in varying degrees of quality care. It has been shown that wealth is correlated with longevity, indicating a link between socioeconomic status and mortality. Hospitals and treatment centers are now widespread across the developed world. Not everyone can afford treatment. Compounding this issue, detrimental behaviors such as poor diet, inadequate exercise, and smoking are higher in populations with lower socioeconomic status. Furthermore, people of high socioeconomic status generally have better continuity of care, fewer costs of complying with treatment regimens, and more knowledge about their care. For example, women with higher income and education levels tend to have better health insurance, increased awareness, and the ability to take time to regularly visit their doctor, and so receive more screenings for cervical and breast cancer. In addition to socioeconomic status, race, ethnicity, gender, mental illness, and disability are also major factors contributing to inequalities in health.
I mean something very simple by productive capacity, which has to do with, let's say, GDP per worker or GDP per capita. Without productive capacity, you don't have the means to realize reductions of poverty, the means to realize improvements in health, the means to realize improvements in education, and so forth, and so forth. I think we're witnessing a sea change in the international order, where finally the dominance of Western countries is being challenged by new emerging economies, such as, most importantly, China and India, and perhaps also Brazil. We are all so involved in development that it is a hugely emotional and political issue. The moment you take a long-term empirical perspective, you have a kind of an empirical basis along which to judge these questions. So we do see that there are progress is being made in both reducing poverty on a global scale. If you look at the calories that people take in, you see advances over a long period. If you look at life expectancy, we've gained 20 years of life in Western countries, and I think 10 or 12 years in developing countries.
For health, what we really mean is that health is much broader than the mere provision of health services. This is a particularly relevant concept for Gaza, where occupation and closure have impacted health through the influence on the housing situation, the conflict context, the water supply. What we really need to do is, if we want that the people in Gaza can enjoy the full potential of good health, we need to address these broader determinants for health. We need to ensure that we don't medicalize a problem for which there is no medical solution. We really need to find a political solution for the housing situation, the water situation, the education, the social situation in which people live here, so that they really can enjoy the full potential of good health.
عماد هم 8 أطفال ساكنة في القرية بدوية. الصرف الصحي بيأثر على البيئة اللي احنا فيه، والله البعوضة كمان يعني بتجيب لي البعوضة كتير، فالصيف ما بقدر انام من البعوضة، هذول طول الليل يحكوا في حالهم، وقسم تكون الكهرباء واطلة، لا في مروحة ولا في أي شيء. يعني كل ما بناخذ الودي بيسهل بنروح نفحص البراز بيقول لي معاه ديدان، كل من صار سبب الصرف الصحي. عنده فقر دم ابن صغير 8 دم، اخذ مفحص لقى 8. كل من قلت التغذية وقلت الأكل وقلت إيش يعني الدكتور وصلنا نجيب له حاجات كبد حاجات هيك نعط مع سن الدم يقوى، ماني قادر أجيب له.
أنا إنسان عمري مقارب 50 سنة، عطنين عن عمل، يعني إنسان عاطل عن عمل، إيش بيكون يعني حالته، إيش مصدر دخل يخش علي، يعني عمل طب هو معه مصاري، يعني بيحاول إنه كله يقدر ما يجيب مش فيش توفير لهم، كيف توفير كيف بدي أجيب لهم إنسان عاطل عن عمل. طبعا أول الحرب إحنا بقينا في الدور هان، يعني أول ما صار في الإيش في القرية الفوقانية من شمال، صار ضرب في الدور عشوائي، يعني شوي صار ضرب عندنا. طبعا احنا شردنا المدارس، لما طلعنا المدارس قعدنا في 8 شهر، يعني ما قام شهر يعني رمضان كله، حتى عيدنا العيد في المدارس، يعني ابو الصف قديش بيساعد 50 واحد أو فوق ال 50 مرة في الصف، فوق ال 200 مرة في الصف، نفس الصف، الأولاد والعيال، هذا عنده 10، هذا عنده 10، هذا عنده 20، هذا عنده، يعني كانوا بعضهم أطفال، حال مأساة لا تقدر يعني.
خلال ال10 سنوات الأخيرة كان هناك أكثر من 3 حروب مر بها السكان الفلسطينيين، المواطن الفلسطيني في قطاع غزة، ذلك بالإضافة إلى حالة الحصار والإغلاق التي يعيشها السكان الفلسطينيين في قطاع غزة، والتي تؤثر بمجملها على مجمل الحياة الاجتماعية وبما فيها الصحة، سواء من حيث تقديم الصحة والخدمات الصحية للسكان الفلسطينيين. هناك تأثير كبير لعدم وجود تنمية حقيقية في قطاع غزة لتحسين البيئة المحيطة بالسكان من أجل مجتمع صحي سليم، فنجد أن أكثر من 95% من مصادر المياه في قطاع غزة غير صالحة للاستخدام الآدمي. كل هذا يؤثر بالمجمل على الخدمة الصحية كواحدة من الخدمات الاجتماعية المطلوب تقديمها للسكان، ويؤثر أيضا على البنى التحتية بمجملها اللازمة للمعيشة في قطاع غزة.
بالطبع أي ظروف بتأثر سلبيا على صحة الفرد أو المجتمع، أكيد حتكون الظروف هذه أكثر تأثير بطريقة سلبية أكبر على الناس الأكثر ضعفا أو الأكثر هشاشة. الأطفال هم أكثر ضعفا وأكثر هشاشة بحكم عدم نموهم الجسدي الكامل، فبالتالي بيكون مناعتهم أقل، يكونوا معرضين أكثر بنيتهم للأمراض المعدية. وحتى الآن نسبة المرضى والوفاة من الأمراض المعدية اللي بتتعلق بالجهاز التنفسي ما زالت بتحتل يعني نسبة كبير في السن، أيضا مناعته أقل، يتعرض لأمراض مزمنة أكثر، فهذا بيزيد من ضعف مناعته، بيزيد من أكثر من قابليته لانتقال العدوى، من أيضا من زيادة الأمراض المزمنة عنده مثل أمراض الأجهزة التنفسية والسرطانات بصفة عامة، لأنه مناعته